When I was training as a doctor, I met a young boy with Tourette syndrome. His father told me that every morning when he got up, he would recite a string of swear words like he was chanting a prayer. From that moment on, I became fascinated by how the brain would create such intricate but abnormal patterns of behaviors, including complex vocalizations. And I soon discovered that there's so much more to Tourette's than a spontaneous swear word or two. I'm Valsamma Eapen, a professor of child psychiatry at UNSW School of Clinical Medicine, and I am researching how the interplay between the brain and the mind shapes our behavior. I want to get to the bottom of what makes those with Tourette's tick and what we can do to make their lives easier. Our story begins in Paris in 1825, where a French noblewoman known as Marquise de Dampierre becomes the talk of the town thanks to her seemingly involuntary outbursts, shouting insults and curses in church and salons of polite society. Her behavior is documented by a physician, but it's not until 60 years later that the Marquise's case is discovered and re-examined by the French neurologist Georges de la Tourette. He was the first to give a detailed account of the disorder. Today, of course, we know it as Tourette syndrome or simply Tourette's. Yet, despite this nearly 200-year history, the condition was not included in the premier diagnostic manual for mental disorders until 1980. And even today, it's widely misunderstood. While we know that people with the condition are deeply affected in their daily lives, the complexity and the variety of symptoms can make diagnosis and treatment difficult. The symptoms of Tourette's typically appear during childhood, in which a person experiences uncontrollable twitches or tics, which can be motor or vocal. These are quick, involuntary movements or vocalizations that occur suddenly and repeatedly. These can be simple motor tics, uncontrollable bodily movements like eye blinking, face grimacing, or head jerking, or they can be complex motor tics, which can lead to seemingly bizarre behaviors that are easily misunderstood or mistaken for intentional actions, like licking, jumping, squatting, kissing oneself, and others. But vocal tics are probably the Tourette symptom that people will be most familiar with. They can be simple, such as sniffing, humming, grunting, or making low or high-pitched noises. Or they can be complex, taking the form of words and phrases, or sudden shifts in pitch and volume during normal speech. And among these, the blurting of obscenities, known as coprolalia, is the most well-known. In fact, involuntary swearing has become almost synonymous with Tourette's today. Some patients have been told by their doctor that they can't have Tourette's if their repertoire of vocal tics doesn't include swear words. But this is a myth. In reality, only a third of patients who are seen in clinics display coprolalia, and out in the wider world, rates are probably even lower than that. Despite these many facets of Tourette's, the disorder is commonly under-recognized, not least because it can be masked by other conditions. Comorbidities, that is, disorders that typically occur alongside Tourette's, are surprisingly common, with up to 90% of those with Tourette's also having another condition. Among these, attention deficit hyperactivity disorder or ADHD and obsessive compulsive disorder or OCD are the most common, occurring in up to 3/4 and half of all Tourette cases respectively. As a result, these symptoms can be misconstrued as deliberate, disruptive acts of behaviorally challenged individual, and Tourette's can go undiagnosed. There can be an expectation among some that someone with Tourette's can control their tics, and that's just not the case either. But we are getting better at recognizing the signs. Take the story of Jacob. Jacob first visited the GP when he was 6 years old, with involuntary eye blinking and a tendency to roll his eyes. The doctor referred him to check his eyesight, but was given the all clear, and after a while it got better. Now that he's 8, Jacob is back at his GP. His teachers have noticed that he's often hyperactive, but other times lost in a daydream. He tends to hum to himself too, which gets him in trouble at school. Jacob's parents are worried about his behavior, concerned that he might have learning difficulties or suffering from anxiety, as he is now showing reluctance to go to school. But the GP notices something else. Jacob frequently scrunches up his face, seems to jerk his head, and is also noticed to be grunting. Taking these into consideration, a diagnosis of Tourette's is on the table. Eventually, it's a family history that convinces the doctor that Jacob has Tourette's. The boy's father recalls how his brother, Jacob's uncle, had what he described as a nervous twitch when he was younger, blinking rapidly, shrugging his shoulders, and making a squeaky noise, especially when in stressful situations. It's likely that Jacob's uncle had Tourette's too. This story tells us a few really important things about Tourette's. Not only can it be easily overlooked, but it's often the accompanying comorbidities that causes concern rather than the tics themselves, leading to a visit to the doctor or attracting the attention of their school. But Jacob's story also highlights some of the complex and poorly understood causes of Tourette syndrome. We know that it has a genetic underpinning. Compared to the general population, parents with the disorder are 18 times more likely to have a child that develops Tourette's. But it's not a single gene that causes it. Rather, there are several neurodevelopmental genes at play that make someone more or less susceptible. And while it appears that environmental and even immune factors can play a part, there's no evidence that Tourette's is caused by trauma or bad parenting, contrary to some schools of thought. There's still a lot to learn about what's happening in the mind and the brain when a person with Tourette's experiences tics. We imagine the mind as having a kind of gate that holds back a lot of brain's activity, keeping us unaware of these sensations. But in Tourette's, that gate is not as effective as it should be, allowing some of the sensory experiences to break through as kind of premonitory urge. The urges can feel like a stretch or tightness or like an itch at the site of the tic. Thus, the urge is responded to with a tic, providing momentary relief before the urge begins to grow, and the cycle of urge, tic, relief gets repeated over and over again. The extent and intensity of those typically wax and wane, so it can be difficult for doctors to get a clear picture of someone's condition. We estimate that around 1 in every 100 children develop the disorder during school age, the majority of them boys. And while symptoms will peak around 10 to 12 years of age, the vast majority of cases improve naturally by the time one reaches young adulthood. We think that whatever is happening in the brain to cause that leaky gate is compensated for as the brain matures and the inhibitory circuitry becomes more effective. And yet 10% of childhood cases will persist into adulthood, often with an intensity and severity that seriously impacts their lives. As well as the co-occurring ADHD and OCD, people with severe Tourette's can develop serious anxiety and depression due to social stigma and bullying as a result of the condition. While there is no known cure for Tourette's, we as medical practitioners find that appropriate treatment and supports can make a huge difference. In our program, we are looking at all aspects, including genetics to the brain circuitry and the comorbidities to treatments. One kind of behavioral therapy aims to break the urge-tic relief cycle by increasing the awareness of the premonitory sensation and doing a competing action, like tensing the opposing muscles, thereby preventing the tic response. And although there's no medication that can cure Tourette's, good symptom control can be achieved using medication and also using behavioral treatments in 60 to 70% of cases. Some, however, experience significant side effects of medication, and alternate treatments such as medicinal cannabis being trialed, including at our unit. It's clear that we have a long way to go in understanding, treating, and supporting Tourette's, but by working to untangle the neurological short circuitry, we stand a chance of improving treatment options and outcomes. In the meantime, we need to promote better awareness of Tourette's and the issues that those living with it face. This will not only help us identify the signs and symptoms and provide the appropriate support mechanisms, it will also help to address some of the everyday stigma those with Tourette's face and improve their quality of life.